Hello everyone, I am Dr. Adarsh, Senior Resident in Neurology at NIMHANS. I'll be discussing OPD cases in this series of Today I Saw, Today I Learned. So last week a patient came to the OPD. Mother walks in with her 9-year-old daughter. The mother looks genuinely worried and she says, "Doctor, my daughter keeps going blank." And then she comes back like nothing happened. So we are going to discuss this case together along with the very close mimics of this case, and you will know what to do exactly in OPD and what to ask exactly for deciphering. Ananya is a 9-year-old child. Her mom brings her in because for the last 3 months something strange has been happening. Multiple times every single day, Ananya just zones out. She stares, she blinks, and she does not respond when her name is called. And each time lasts maybe around 5 to 15 seconds. And then she snaps right back. She is absolutely back to normal. Like absolutely nothing happened. There is no confusion after the episode, no tiredness, just back to normal. Her teacher have noticed it too during the class twice, and her grades have started slipping. There is no jerking of the limbs, no tongue bite, no wetting herself. She has never fallen during one of these episodes. And there is no family history of epilepsy. What do you think is the most likely diagnosis? Choose one of the options. The first option is childhood absence epilepsy. Second is juvenile myoclonic epilepsy. Third is focal impaired awareness seizure. And fourth is daydreaming. The correct answer is A, childhood absence epilepsy. So why CAE? Ananya is a 9-year-old. CAE usually happens between age 4 and 10, almost always. And the spells are very brief, lasting for a few seconds, like 5 to 15 seconds. And they start suddenly, abruptly, and they end suddenly. And after the episode, the child is back to normal completely. There is no confusion, no sleepiness. And that is the history of typical absence seizure. Now let us talk about the other options because they are all possible. Option B is juvenile myoclonic epilepsy. It is also an epilepsy syndrome where the absence seizure can occur. But JME usually occurs a little late, and the hallmark of JME is jerking of the arms. Myoclonic jerks happen, which usually happen in the morning. And Ananya has no history of any of that. Option C is temporal of epilepsy. This is a very close differential. Temporal of epilepsy causing focal seizures with impaired awareness. But TLE spells last much longer, over a minute, and after a focal seizure episode, the patient is confused and drowsy for several minutes. This is the key point that you must remember for differentiating it from typical absence seizure. In our case, Ananya snaps back immediately. Thus, the absence seizure is the correct answer. The fourth is daydreaming. So, daydreaming is very common, and children not paying attention, blanking out in class can happen in daydreaming also. But when you call out the name of the person, name of the child, she will respond. In this case, the patient did not respond when you call out her name. So that is what is differentiates. Does the patient respond when you call her name out? So absence seizures do not interrupt with external stimulation. So let us now talk approach. When a child like Ananya walks in, what exactly do you ask? What do you look for? In the history, you are looking for the classic cluster of episodes like brief, abrupt, multiple times a day. There is sometimes can be eyelid flutter, and this is one of which everyone forgets. That is immediate return to normal. How was the patient after the episode? If someone tells you that the child is confused or sleepy after the episode, you should be thinking of something else like focal seizure with impaired awareness or other things. And equally important is that what is not there, to take good negative history. There should be no aura, no jerking, no falling, no incontinence. In CAE, the absence of these features is as meaningful as what is present. When you're taking a history, you have to ask explicitly about each of these. Now in examination, you can do 3-minute hyperventilation in the OPD. You can ask the child to blow on a piece of paper or to blow on a pinwheel in your OPD right there in front of you. Ask the child to breathe fast and deep for 3 minutes, and in most CAE cases, you will watch an absence happen. Now in the investigations, you can do an EEG which can confirm it. The EEG will typically show 3 Hz spike and wave pattern. Now let's see a close case. Rahul is a 12 years old child, and Rahul also has staring spells. Rahul's spells last 60 to 90 seconds, that is 5 to 10 times longer than Ananya's. And after each spell, he is confused for 2 to 3 minutes. He can't tell you what happened, he does not even remember having a spell. And during the spell, his mother notices that he smacks his lips and picks at his shirt. These movements are called automatisms. And Rahul also feels a rising sensation in his stomach just before the spell starts. So An MRI was done, and MRI shows a small lesion in the right hippocampus. So what do you think is the most likely diagnosis in Rahul? Is the option A is correct, childhood absence epilepsy? So what are the red flags in this long duration of a spell? Even more important is the child was confused 2 to 3 minutes after the episode, which does not happens in absence epilepsy. And the MRI is usually normal in absence epilepsy. So A is wrong. B is focal impaired awareness seizure. So this is the typical description of a focal impaired awareness seizure, in which the patient would be confused and drowsy after the episode. The third option is syncope with secondary automatisms. In syncope, the patient would not be confused for so much time. Let us see the third case. This one is really important because this is the child who often ends up in neurology clinic after being told for months that she is not paying attention in the school. Priya is an 8 years old child, same complaint, zoning out in the class. Teachers are frustrated because of that and parents are worried. But her story is different from Ananya's. When Priya is called by her teacher, she looks up immediately. She responds, which means she is interruptible. This is the single most important thing that you remember today. An absence seizure can't be interrupted by calling the child's name. Daydreaming can be. That one feature can differentiate between daydreaming and an absence seizure. And also Priya's episodes last minutes. They happen when she is bored, they are variable. Spells are consistent, same duration, they look typically same. That is staring, blank spells for seconds every time. And also her EEG is normal, which is exactly what you expect in a daydreaming episode. So the correct option in this is, what feature most distinguishes this from the absence epilepsy? The answer would be, it responds immediately to name calling during the episode. This is the table showing the differences between the absence epilepsy, focal impaired awareness seizure, and daydreaming. Only 2 points I want you to remember. The first is whether there is post-ictal confusion or not. There will be no post-ictal confusion in absence epilepsy, and it will be present in focal impaired seizure. The second is whether the episode can be interrupted. So that will differentiate absence from daydreaming. So if the episodes can be interrupted, then that is daydreaming simply. If the episodes are not interrupted, then it is a true seizure, which can be absence or focal impaired awareness seizure. EEG, neuroimaging, and additional workup can play an important role in confirming the diagnosis. So if you are seeing 3 Hz spike and wave appearance on EEG, then that confirms the presence of absence epilepsy. And if there is focal discharges, focal slowing is there, then that is more likely with the temporal of epilepsy, which is a cause of focal epilepsy. And video EEG, if the diagnosis is uncertain, then you can do video EEG, where you can correlate the clinical behavior of the patient with the discharges happening in the EEG. MRI brain is not mandatory in every patient. However, if the patient has focal symptoms or atypical features, or the patient has other red flags like cognitive regression, drug resistant, then you can proceed for MRI brain. Additional workup like blood glucose, electrolytes, calcium should be done in every patient because they exclude metabolic causes of staring spells and other causes of seizures. Okay, we have made the diagnosis. Ananya has childhood absence epilepsy. So what do you actually do? First line is Ethosuximide. Ethosuximide, we start slowly and it works beautifully in CAE, good seizure control, and importantly it has least impact on the cognition compared to Valproate. Valproate is also a good drug, but it is teratogenic, and so we avoid especially in the girls. Now, why it was so important to differentiate focal seizures from the absence seizures, focal seizures with impaired awareness from the absence seizures, because the drugs used in focal seizure is carbamazepine or oxcarbazepine, which can worsen the absence seizures. Now, monitoring is simple. You have to keep a seizure diary and repeat EEG and talk to the school. Make sure that the teacher knows what a spell looks like and that the child is not just distracted. And the best part of this whole conversation, that 60 to 70% of these children will outgrow their absence seizure by mid-adolescence. And that prognosis is excellent if there are typical absence seizure like this. Let's summarize. 1. Brief staring spell, immediate recovery, school-age child, think absence seizure first. Second, if the child does not respond when you call their name during the spell, that is a seizure, not daydreaming. Third, hyperventilation in your OPD, you can diagnose absence seizure. It precipitates absence seizure in 90% of the cases. Fourth, if you do EEG in a patient with absence seizure, it will show you typical 3 Hz spike and wave appearance after the stimulation, after the hyperventilation procedure. Fifth, Ethosuximide is the drug of choice. If it is not available, then you can use Valproate. It works good. Carbamazepine can worsen it. And the sixth, the good news is that 60 to 70% of these children will have remission of these seizures by the adolescence. Thank you.